There was a comment made that I couldn't get rid of, is that in the United States, research is apparently in the private sector, and in Canada, it's university. There's exceptions to the rule. I agree that Buffalo is on the border of Canada and the United States, but it's still the USA. So I'm going to present my research that I have done. Now, my background is I have 5 board certifications, professor of neurology, oncology, neurology, headache medicine, and neuroimaging. And so I went through the academic world. And the last time I gave this talk was at the American Academy of Neurology, where there was 400 people in the room, and they had to get an overflow room to tell you the interest at the neurological level in academic medicine. So there's a tremendous interest, and I would love to see more physicians come down for this meeting, because I think it's well worthwhile to network with that physician group. So I'm going to, as you can tell, I presently run about 110 research studies with pharma. So I'm in bed with pharma, big time. And in fact, when I talk about migraines, the last 8 drugs that have been FDA approved, which is worth, what, billions for each company, 8 different companies, I was part of the research team that did that at our institute. This is the institute, and I think the most important part of it is the 13,000 cannabis patients that we actively see. So you understand that this neuroscience center sees about 1,300 patients on a daily basis. So of those, 250 are migraineurs or headache patients. So that we have a huge volume. And the reason I chose migraines, being the director of the migraine and the cannabis clinic, is that it was so easy to do. I'm a chief of neuro-oncology, so I was very much interested in the glioblastoma literature in cannabis, which is very new, probably more advanced in England and Spain. But also, I run a center in Europe called the Mind Clinic, and that's in Budapest, Hungary. It's a neuroscience center. So this is a breakdown of our cannabis clinic. So we have 13,007. That's pretty up to date. This is in the New York State medical marijuana program, or cannabis program, as I like to call it, is quite regulated, quite expensive, but you know, I'm about 10 or 11% of the whole state seeing patients. So we see a significant amount. As you can tell, chronic pain is 78%, and you go down the list of cancer, neuropathies. Many of the chronic pain patients, by the way, have cancer and other disorders. So I did one thing. I told the patients, I won't accept a dollar from you in cash, but then you have to fill out all this data, and that's your sacrifice. And they, trust me, they agreed to that. So we have a huge amount of data intake. We don't send patients away for a year. We bring them back depending on the disease state, but no longer than 2 to 3 months. So this way, I'm gathering the data, and I agree, as somebody who runs randomized studies, I'm going to talk to you about large population retrospective studies. The criticism of cannabis research over the years has been obviously that the numbers have been relatively small. So I talk about legitimacy only because my fight is not with the cannabis users or the business. My fight is to talk to the academicians, the presidents of societies, and change their attitudes to cannabis. And I know a lot of people in the audience, Bonnie, Ethan, Dustin, have also had this fight for many years, some longer than others. But it's a long-term fight, and I didn't understand that fight until I got into cannabis about 7 years ago, which is when New York State legalized it. Now, one of the other reasons is that as a migraine specialist who runs probably the largest migraine center in the country, many of my predecessors, the people I looked up to, were actually Gowers from England, who was a neurologist, a father of neurology, or Osler, the father of modern medicine from Canada, who developed Johns Hopkins. These individuals, in their books at the turn of the century, the previous century, wrote about use of cannabis in the treatment of headaches and migraines. So in fact, that was probably one of the most common cause. And O'Shaughnessy in Calcutta did the first scientific studies of pain, endometriosis, went back to England to treat the Queen at that time. And this is something you all know, is that cannabis or marijuana hashish extracts were the first, second, and third most prescribed meds between 1842 and 1890. If you don't know the history of what happened, and I presume this audience does, look it up, review it, because it's really opens your eyes how politics, business influence medicine. So this is two studies that I'm quoting you. So I firmly believe that people ask me, do I smoke? I said, I don't. But I don't even drink, and I don't smoke tobacco. But many of these so-called alcohol is being used for medical reasons. We all know that many alcoholics become alcoholics because of underlying anxiety, depression, PTSD. So the bottom line is that in my opinion, more people use medical marijuana recreationally, medically than recreationally than we understand. I went to Colorado at the beginning of my search for this knowledge, and I went to a bud tender in Colorado and asked him then, what CBD products do you have? He said, we don't have many CBD products. I go, so everything we have is THC. I said, why is that? Because everybody wants to get high. I said, well, how about my grandmother who's got rheumatoid arthritis at age 78 and needs some kind of cannabinoid? And the reply was the same. She wants to get high. And that's not the fact, because in my 13,000 patient, the question I ask routinely, it's on the data, do you get high from the cannabinoids I'm giving you? And the answer is, in 99%, no. So there is this population out there, and I'm talking about medical marijuana, not recreational. Some people drink alcohol to get drunk. Some people use alcohol on a daily basis to maintain their quality of life, whatever that may be. I'm not going to review that, but the endogenous cannabinoids, which have well been discussed, and phytocannabinoids, we all know these types, and some of these researchers are in the audience. I also don't believe in sativa and indica and strains. I usually use the type 1, type 2, type 3 cannabis, chemovars, which I noted above here. And the clinical endocannabinoid deficiency is something I'm really interested in, because as a neurologist, I treat a lot of people with Parkinson's disease. And Parkinson's disease is a lack of dopamine. Alzheimer's, a lack of acetylcholine. Depression, a lack of serotonin and norepinephrine. So we have these deficiency states in the diseases that I treat on a routine basis. And the endocannabinoid deficiency syndrome, and by the way, the endocannabinoid system is not taught in medical schools except for about 8%. So there's this obvious ignorance, and I use the term ignorance loosely, that physicians don't understand it. And because they don't understand it, a physician will then build those walls around them and say, not for my patients. So we have to educate at the medical school level about the endocannabinoid deficiency. And I have to commend Ethan Russo, because he's one of the strong voices in this community that really tries to make physicians understand. And I say try because sometimes it doesn't work out. And he's already laughing because he knows I'm going to show that slide that I have to get to you. Because it's very important to understand that the endocannabinoid deficiency may be occurring in disorders beyond migraine. And if you know the definition of comorbidity means that you have one disease and another disease happens in that one individual that's statistically higher than by incidence. For example, migraineurs have a higher incidence of fibromyalgia, idiopathic bowel syndrome, post-traumatic stress disorder, bipolar disorder, anxiety, and so on. So these circles envision a subset of a population, which is rather significant, because if you look at migraine, the incidence of migraine is 12%. The prevalence rate is 12% around the world. In women, it's about 18%. And in women between the age of 20 and 40, it's close to 40%. So 40% of women in here are migraineurs, if they know it, or maybe they don't know it. But I promise you that migraine is a disorder that is tremendously easy to do research on, because we have a strict criteria what a migraine is based on the International Headache Society classification. So these disorders are natural to be treated in our clinic. This is in Pasadena, I think, recently. Last time, I think Dr. Michaud came to the United States, and I had an opportunity to talk to him about his theories about the use of cannabinoids in headaches and so on. And obviously, he's a pioneer and I don't know if we call it grandfather or godfather of research in cannabinoids. So we know about all this. I'm not going to go through this but this is the picture I wanted to show you. The individual way on the left is the president of the American Headache Society. This is at the American Headache Society, Dr. Silverstein, then there's myself, and the one who's got the microphone is Ethan Russo. And the one next to him is the next president of the American Headache Society, and coming from London, England, originally from Australia, which maybe I'll leave his name out for now. But the bottom line is, as Ethan is appropriately answering a question in an audience much bigger than this, he got up and said, "This is bullshit," and left the panel. Now, you don't see that in academic medicine. I think you don't see it in many places. I hope Dustin doesn't come up here and say this is bullshit and pushes me because he has that potential. I saw him dance yesterday. He's got a potential for a lot. So the bottom line is, this just tells you the internal resistance from academic medicine toward individuals who have really put their academic career and their life for a cause as advocacy and with science. So this just tells me about headaches. Now, migraines I won't get into, but I will tell you the migraines is one of the most common disorders. In fact, according to the World Health Organization, WHO, chronic migraines is the second most disabling disease in the world. First one is low back pain. And so if you're a migraineur, you can see how much one suffers. That's episodic migraine, which is on the left, 4 to 72 hours, allocation, pulsating, moderate to severe, aggravated by causing physical activity. You have migraines with aura, but that's only about 15 to 20% of all migraines. So people say, "Oh, well, I don't have an aura, so I don't have a migraine." Not true. Chronic migraine. 40% of my clinic is chronic migraine. By definition, more than 15 disabling headaches a month, of which 8 have to be migrainous, lasting more than 4 hours a day. So this is the definition of International Headache Society definition of migraine. This is a migraine. There's a prodrome, which could last 24 to 36 hours, where you have mood changes, cravings. For example, everybody thinks, well, I ate chocolate, and now I got a migraine, and chocolate caused a migraine, when in fact, maybe the craving, a hypothalamic phenomena, is the cause of your craving for chocolate, and it's part of the migraine itself. The aura occurs in 15 to 20% headache phase, postdrome. All right, so the numbers are huge. So if you want to try or study a disorder in medicine, then migraine is ideal, because these patients are quite frequently in our practice, and quite easy to treat, because migraineurs tend to have a higher medical knowledge than non-migraineurs, and that's been shown. I'm not going to go through the pathophysiology, but it's interesting that the cortical spreading depression is an electrical phenomena that was outlined by Leo from Brazil, and then it goes to the migraine generators in the brainstem, the raphe nuclei, the locus coeruleus, and then through the trigeminal vasculature, with CGRP being a new entity. Now, CGRP, I listed 1, 2, 3, 4 CGRPs, but there's 3 other ones called Also, so I studied 7 CGRPs. All 7 were approved by the FDA. So yes, I'm a superstar in headache medicine because the pharmaceutical companies love us because we did this study, and it was not just at my institute, it was a multi-center study. The other GPANs are called the ones listed above. These are the ones on TV, Ubrelvy, Nurtec, and so on. Triptans came out in 1992. We thought that's going to change headache medicine. It did somewhat. Ergotamines we don't use anymore came out in the 1920s. But Botox, which is neurotoxin, is still approved for chronic migraine. We also do research in neurostimulators, and then I add cannabis at the end. The thing about chronic migraineurs, people with chronic migraine, by the IHS definition, they have low anandamide levels. So this is somebody asked about, can you do spinal taps on these patients? Well, this is a study looking at spinal taps on patients with migraines and looking at anandamide levels or endocannabinoid. And by the way, in chronic migraine, they're low. I truly believe that when I see a patient, and I see a lot of patients, is that there's some patients will respond to cannabis wonderfully. And they say, you changed my life. Some people don't. And I truly believe that this is part of the endocannabinoid deficiency syndrome, where phytocannabinoids supplement endocannabinoids in individuals who have low cannabinoid levels. So anandamide levels have been shown low in chronic migraine. So this is some of the studies we've done. So we did initially we did 263 patients. Obviously we have more than that, but when we have to go back, 88.9% reported improvement in migraine. 83% of patients reported improvement of their headaches besides migraine, and 51% on opiates were able to reduce their consumption completely or significantly. So this is a chronic migraine study. So the efficacy of medical cannabinoids seems to be dependent on the ratio of THC and CBD. What we use, because we know the ratios, the one criticism on New York State cannabinoid program is it's expensive. The positive is that it's regulated relatively rigidly and strictly. Appearance of a distinct group of receptors, type 1, type 2, I'm going to show you. And what's interesting about this cannabis and chronic migraine is I did that in parallel to CGRP monoclonal antibodies. These are shots given once a month or an IV once every 3 months, if you're familiar with these drugs. Those drugs have been approved by the FDA, and the cost of that drug is about $8,000 a year. Now, insurance companies have accepted the research and are now paying for these drugs $8,000 a year. They won't pay for cannabinoids, but they'll pay $8,000. Botox is about $5,000 to $6,000 a year for chronic migraines. But the results of the studies, albeit my study was retrospective, but parallel to the other studies I did with pharma, and you could see the results in 171 patients, there was a 25.7% of patients had a 75% improvement in headaches on cannabinoids. That number is remarkable, by the way, if you deal with headache medicine. I think we have neurologists in the audience. But you look at 63.2% had a 50% improvement of chronic migraine, which the WHO has stated is the second most disabling disorder in the world. So 50% improvement of this population, which is the worst of the worst, by the way. Many of these have sleep disturbance, comorbidities of depression, anxiety, fibromyalgia, go down the list, irritable bowel syndrome. So this is a population that, now even 80% said there was a 30% improvement on cannabinoids. And so these numbers are actually, if you look parallel to the CGRP monoclonal antibodies that were approved by the FDA, are very similar numbers, except one's retrospective and the other one is randomized studies. And I agree with academic medicine that randomized studies have to be done, but that's the next question, who will pay for that? So, and then this one here, 63% responded, very similar to all the CGRP monoclonal bodies. And this is the cannabis and chronic migraine in this population, and 41.8% decrease in headache days per month, and then the average decrease in monthly headache days was significant. So cannabis can work in chronic migraine by improving the depressive levels, anxieties, analgesia, anti-inflammatory. There's many reasons why, and I on purpose did not get into the pathophysiology of how cannabis affects the central nervous system, because a lot of this information was given to you. So this is the cannabinoids I use. So first question I ask, are you naive or not naive? It's a simple question. So most of my patients are in the 60 and above, so most of them are quite naive. So I'll use this titration schedule. In patients who are naive, I start lower. Patients who are not naive, I start higher, and I may give a higher THC comma. If they're smoking it and they want to switch over, because people are realizing that as much as we love our cannabis, there's got to be a way that we're going to find better than smoking it. Or vaping it. Now, vaping it has shown to be less toxic to the lung than smoking, and the literature has not come out with cannabis smoking is associated with a higher incidence of lung cancer like it is with tobacco. Probably because most people are not smoking as much, although you're inhaling it deeper. So I'm not sure that literature is going to stand for a long time. We'll find out. But you remember, I'm an oncologist too, so I have to respect that. So cost barrier is the major issue for me. When I treat patients, I bring them back. If they don't come back, I give them a call. My staff does, and says, why did you not come back? Why didn't you go to the iStop? I looked at the iStop, which is that regulatory state-run system that I know when they pick up the opioids, the benzodiazepines, or the cannabis, and they didn't go pick it up. And I asked them, why didn't you do it? So the numbers are straightforward. Then I looked at zip codes. I looked at all the people who went and said, I can't afford it. I looked at zip codes. And do I have to tell you what the zip code showed in my part of the world, Western New York? The zip codes were downtown Buffalo. It was totally on income and race, which is why we put these systems together. It's not working. And I know that. And I have a lot of meetings with politicians to say, look, you put a system together and it's just not working for the population that we need to be more cognizant of. So the barrier is this. So this is the article I recently wrote. It came out 2 years ago, or now 2 years ago. And it's Cannabis and Migraine. It's complicated. I'll urge you to review that. So my conclusion is cannabinoids work because they're anticonvulsive. And the reason migraine is not a seizure, but migraine has ion channels, as has epilepsy. So there may be a correlation, analgesic, antiemetic, anti-inflammatory. It's a promising compound. Yes, we do need randomized study. I have a few things here of post-concussive headaches and chronic pain. And all I can tell you in this study we've done, 80% showed subjective improvement on post-concussive and chronic pain. 80% of improvement was sleep, 70% improvement. And the treatment I use usually is a 20-to-1 oral tincture, which I titrate slowly. And then this is something in the opioid epidemic we have right now, which is a real serious problem that has to be addressed, is that if you look at opiate consumption, look at the different diseases. TN is trigeminal neuralgia. These are the decreased amount of opioids they use based on the different disease states. But across the board, you'll see, especially fibromyalgia, at 63% come off opioids. This is important reduction of opiate consumption and should be studied to the hilt, especially now in the study. Now, this was interesting. Trigeminal neuralgia, another pain syndrome, lancetating pain. And the results were really unbelievable. 81% reported significant subjective improvement. So I'm going to go by fibromyalgia, anxiety. I'm going to go that. Wherever the art of medicine is loved, there's a love of humanity, Hippocrates. And I thank you very much. And I thank my team also. So thank you very much.